Dear friends, members of the CMC community, our well-wishers, those who have come here to attend in person and those attending online, it's my pleasant duty to welcome each one of you to this meeting, the first of the series of heritage lectures. As you all know, this year marks the 100th year of the starting of services in the town campus, and Jan 1st, 2025 would mark the 125th anniversary of the birth of the Christian Medical College. In the light of these historic milestones, various activities have been planned and some of them have taken off quite successfully. That was planned to look at the beginnings, growth, and future of various departments of CMC, starting with the older ones in the town campus. I sincerely hope that these attempts of looking back at our past will inspire us to do things better and encourage us when we go through trying times. There is one more thing that the revisiting of history helps, which in the words of the philosopher George Santayana goes like this: those who cannot remember their past are condemned to repeat it. I thank God that we can witness today the fruition of those plans, thanks to the Department of General Surgery, who have come forward to initiate the Heritage Series and the kind support of many dear friends. In the coming weeks and months, we also hope to see other departments share their past, present, and their vision for the future with us. So without further ado, may I request Dr. Inian, the current head of General Surgery, to come forward and take us through today's session. Thank you all once again for joining us this morning. God bless.
Good morning to you all, and thanks, Dr. Abi, for the invitation for the Department of Surgery to start this heritage series. In fact, when Dr. Abi asked me told me about this about a couple of months ago, the first person that came to mind was Dr. Banerjee. We are indeed privileged to have you here, sir, to share your, the history of surgery, and there can be no better person. So I think the next generation, which is, us and the registrars and the young surgeons sitting in front here, should carry this forward. This book needs, a revision. I'm sure, sir, we will probably look at this also. So without much ado, now I would invite Professor Banerjee Jesudason, the former head of surgery, to come over. Thank you, sir.
Good morning. Thank you, Dr. Inian Samarasam, and the members of the Department of Division of Surgery for inviting me to share with you my experience in and the knowledge of our department in the context of its celebration of 120 years of its existence in CMC and 100 years of its existence in the CMC Town Campus. Most of what I'm going to share with you all this morning is in the book I have written titled Our Heritage, Our Horizon, and Our Vision, published soon after the formal celebration of the Diamond Jubilee of postgraduate training in general surgery on 25th February 2012. As mentioned in the book, the talk that I am going to give today actually is dedicated firstly to the founding faculty of the department and those who followed them during the formative years of the department, whose untiring and selfless service and efforts led to the establishment and development of the Department of General Surgery at the Christian Medical College, Vellore, which is our heritage. Secondly, all the postgraduate trainees, past and present, who during their time in the department and in the institution have contributed and continue to contribute to patient care and academic profile of the department. to define its horizon. Or thirdly, all the past and present faculty whose deep commitment to the Department of Surgery and the institution has helped and continues to help the Department of General Surgery to take strides of progress and remain relevant and dynamic, guided by a vision in tune with the motto of our institution, not to be served, but to serve. The year 2024 is an important milestone in the history of the Department of General Surgery in Christian Medical College, Vellore. It is the centenary celebration of its presence in Vellore Town, otherwise Thottapalayam, our main hospital campus. As a prelude, I would like to highlight the origin of the Department of General Surgery in the context of the origin of CMC Vellore Town Campus. Often, this is, as I mentioned, is referred to as the main hospital campus. The first hospital built by our founder, Dr. Ida Sophia Skirder, was Mary Tabor Shell Hospital for Women and Children in 1902, which was a 40-bed general hospital in the center of the then Vellore town, built with funds donated to Dr. Ida Sophia Skirder by Mr. Robert Shell, the president of Bank of Metropolis, New York, US, in memory of his beloved wife, Mary Tabor Shell. The bed strength gradually increased to 60, from 40 to 60. By 1910, there were indications that the facilities at Mary Tabor Shell Hospital would soon become inadequate. And at this stage, a conviction dawned on Dr. Ida Skirder that a vision to serve women and children of India would find its true fulfillment only if the torch of her vision and the divine calling that she received in 1890 in Tindivanam was passed on to Indians. This picture that you see here is exactly was the bungalow in which she was living, caring for her mother, when the three knocks came, and she could not help that. And the next day she saw 3 dead bodies being taken out. And that was the starting point of this, I would say, her vision. This building doesn't exist anymore, but I took this picture and I went and stood inside the very room where she heard the knock, and it was an aura. And so this conviction of hers led her on to the idea of training Indians as doctors. Initially, she came to serve, but later on she realized it's not going to happen during her lifetime. If it has to go beyond her lifetime, she has to start an institution to train the locals as doctors. So this conviction actually led her on to the idea of training Indians as doctors. And this was the origin of Medical Missionary School for Women in 1918 in the Mary Tabor Shell Hospital. At that time, the doctors were initially trained as LMPs, or licentiates of medical practice, and later as diplomates of medicine and surgery, DMS. The medical school, what you see here, is the very first medical school which was formally inaugurated by Lord Penlyn, on whose name Penlyn Hospital was named. He was the governor of Madras Presidency, and this was inaugurated on 12th August 1918 in a rented bungalow on the officers' line. The officers' line is a place, a lot of bungalows where they once upon a time, even when we were medical students, and this is one such thing. And today it doesn't exist because that was knocked down on what you say, this Joy Alucas and Harish Food Zone have been built. But that is the place that our medical school started. It is a bungalow, a rented place. Now the medical school, this particular bungalow, was in close proximity to Uris College, belonging to Reformed Church in America, from which the Scudder family came. And so this is close proximity to the Uris College and Mary Tabor Shell Hospital. So this strategic location facilitated availability of lecture halls and laboratories and faculty of Uris College for teaching basic sciences, and the hospital for clinical training in patient care area. Makeshift anatomy dissection hall in form of a small thatched shed was constructed behind this bungalow. Now, having said that, even when we were medical students, the earlier batches, we joined in 63, the earlier batches had to go to Uris College for basic sciences because they, in MBBS course, the first year was basic sciences. So we didn't have basic sciences facilities in our medical college. So some of us, later on came, when we came, basic sciences were also taught in, but before that, it was Uris College which helped us. Now, all the above arrangements were actually planned only as temporary measures to address the immediate need for starting the medical school. The idea to build the main hospital in its present location in Thottapalayam was conceived in the founder's mind in 1914. And the plan for building the hospital crystallized in our mind in 1921. The first phase of the hospital building was completed by the end of 1923 and was named Coal Dispensary. This was Coal Dispensary, and after Ellen Cole of Massachusetts, USA, whose generous donation actually made it a reality. Now, what you see here is the main hospital. I mean, this is where the hospital started, and it was the administrative block. And what you see is that clock tower actually was built by the citizens of Vellore to celebrate the 25th year of her service in Vellore. And this is the entrance with a silver gate. Now, the silver gate today, what was there is today is actually at the entrance to administrative block. What they would see as a registration counter there, but what was there as a silver gate is shifted to here, the entry to administrative block. 2024. So the first department to shift out of the Mary Tabor Shell Hospital was Department of Surgery. That was the very first department which came out of that place. And today, therefore, is our centenary year of our existence in this campus. Other specialty departments needed for starting the medical school, like pediatrics, OB-GYN, or maternity and gynecology block, were built in the town campus with funds generated from the donors, and those names, they were known after their name, the donors. So, as evident above, the specialty facilities were built in the main hospital as individual buildings. When they built it, it was not together. Today we have connection, all these things are connected. But when they built it at that time, there was no connection. So they were called hospital. There was no, because there was no physical connection between the buildings. So each of these was referred to as separate hospitals. Ellen B. Scrip Hospital for Women. Later on, we called it G ward. I don't know what it is called today. Still G ward? Okay. Ewart Maternity Gynecology and Gynecology Hospitals and Weyerhaeuser Hospital for Women. In 1926, the Governing Council of Medical Missionary School for Women decided that once all the departments have moved into the new town campus, the Mary Tabor Shell Hospital will be closed down completely as a general hospital. However, the Department of Ophthalmology remained there, and the campus has been named as Shell Campus of Christian Medical College. In addition to ophthalmology, the Shell Campus also houses the Department of Family Medicine. This indeed is a living monument for our institution, reminding us of our origin. So when you look at Shell Hospital, it's a reminder of our origin. All departments needed for the medical school moved into the hospital campus, and the hospital was inaugurated by Viscount Goshen, the governor of Madras Presidency, on 5th March 1928. So this is how the outpatient waiting area was. At this stage, the medical school, what we saw earlier, located in the close proximity to Shell Hospital, and was shifted to main hospital campus. And the medical students, who were then all were women, so they shared the infrastructural facilities of College of Nursing for their stay and for their training. And this arrangement continued till 1930, when the Bagayam campus was built and was ready to accommodate them. The Bagayam campus was formally inaugurated by Sir George Frederick Stanley. After him, Stanley Medical College is named. He was at that time, and also Lady Beatrix Stanley. They were high officials in the government at that during the British time. In July 1938, coinciding with the 20th anniversary of medical school, that LMP and DMS courses were abolished throughout the Madras Presidency. However, the LMP and DMS doctors were given an opportunity to become graduate doctors through a 3 or 2 year courses, shortened MBBS course, respectively, in one of the already existing medical college like Madras Medical College, Stanley Medical College. Thus, in 1938, there was a dire need for the missionary medical school for women to be upgraded to the status of a medical college and become eligible for affiliation to the University of Madras for training women graduate doctors. Now, in order to achieve this objective, the expansion of infrastructural facilities for patient care had to include accommodation of male patients. Because it was only for ladies and children. So they had to open the hospital door for male patients as well. To begin with, A ward alone was adequate. Now, A ward is where your present emergency services are. But that is what A ward, that was the first general surgery ward. That alone was adequate at that time for surgical patients. However, the consistently increasing clinical work and the fact that the hospital needed to be upgraded for university recognition as medical college, this necessitated further increase in bed strength to 500. Therefore, B ward was built on top of A ward. The B ward was designed and was designated for clean surgical cases. The A ward became for septic cases, or what we used to call as casualty cases, septic cases. Anybody coming with sepsis, they were just later on only, after we were sure that there is no sepsis, we were shifted to B ward. So B ward was designated for clean surgical cases. It was known as clean surgical ward. And A ward, where the present accident emergency received for infected cases. And this was also referred to as septic surgical ward. A ward also was designated for treating burns patients. When B ward was nearing completion, this is a very interesting thing. When I was nearing completion, Dr. Jesse Finlay was a companion of our founder, Aunt Ida, the then head of the Department of Surgery, and the doctors, other doctors in the department, all were lady doctors then, and Ms. Lorna Shute, the operating room supervisor, and her colleagues in the nursing service, who knew machine stitching, used to meet every night after dinner and stitch gowns, sheets, draw sheets for the new surgical ward. Now, the surgical faculty of during the formative years. The first faculty in 1925, Dr. Ida Sophia Scudder became the first professor of surgery, and Dr. Jesse Finlay, assistant professor of surgery. Both professional and academic activities of the department were shouldered only by them till 1940. Once the decision was made to upgrade the institution as a medical college, the Missionary Medical College for women affiliated to the University of Madras, the admission for MBBS course began in July 1942 with 25 women medical students. However, because of lack of university-recognized faculty for teaching and inadequate clinical material in an exclusively women and children's hospital, the first 3 batches of MBBS students had to undergo short-term postings in Government Pentland Hospital in Vellore Town and Government General Hospital in Madras, Chennai, for required clinical experience and training, because the inadequacy of cases for teaching. The earliest surgical faculty to join the institution were Dr. McPherson, Dr. McPherson, Norman McPherson, whom you see here, and Dr. John Spencer Carman, whom you see here, teaching the medical students. He was our former director, one of the earliest directors. Paul Wilson Brand, Dr. Paul Brand, after whom Paul Brand building is named. Then, next, Dr. Frank Garlick. And then this is actually the Dr. McPherson. He is operating, and I just pasted a picture over there that he is actually McPherson. The year 1945 was an important milestone in the administrative protocol of our institution, when it was decided that the property of Missionary Medical College for Women, owned by the Reformed Church in America, or RCA, the parent church of Dr. Scudder, would be owned by an association of churches and church-related organizations in India, the Christian Medical College Vellore Association. And since then, our institution is known as Christian Medical College Vellore. Now, simultaneously, it was decided that in the co-educational medical college for for the future, the privileges enjoyed by the women would continue, and the admission policy would ensure that the total number of women admitted to the college each year would never be less than 25. So we had our own system of selection those days. We didn't have NEET and all. At that time, we had our own system, and then it was decided by the council that to respect the origin of this hospital as a woman, we must make sure it should be, even if the men students had scored higher marks, they had to cut down. They had to ensure at least 25 ladies were there in the first year when they came. So in 1948, the Department of Surgery was divided into 3 units. Till then, it was a single unit. So it was in 1948, the Department of Surgery was divided into 3 units, which paved the way for further progress and postgraduate studies in general surgery. And that was the time the so-called clinical meetings were established, because you have 3 different things located in 3 different wards, but how do you all come together? So the idea of a clinical meeting, which you all have today, after meeting and breakfast, it was a kind of a fellowship which was established at that time. And of course, later on, we shifted it to different locations and different timings. Then finally, we decided the best time to have this, everyone coming together, is don't eat at home. Don't give that as next, I have to have my breakfast. No, come over here, have the clinical meeting, have a breakfast, and enjoy the fellowship. So this is our department. It is the only department which enjoys this facility. There's kind of a fellowship together once a week. Okay. And this also, actually, this kind of, so in surgery in 1950, this was 58, this division takes place. And in 1950, the postgraduates we were recognized for postgraduate studies. And the first person who was selected was Dr. H.S. Bhatt. Okay, Dr. Sitaram's father-in-law. Is Sitaram here, by the way? No. Okay. So this kind of a division is ensured an effective human resource development for the Department of General Surgery, dividing into different and starting our own postgraduate studies. So that is when all our own postgraduate studies, our own postgraduates started joining after completion. So our department has this rich heritage. So it's not only for the development of the department, but also the development of higher specialties in our institution. By now, the Department of Surgery in Vellore was well recognized, and the very first National Conference of Association of Surgeons of India was held here in CMC. And in 1952, the very first ASI conference was held. And where was it held? Not in a 5-star hotel. It was held in men's hostel, which was still being built, and everybody stayed there and enjoyed. But today, can you imagine any of the national conferences being held in a place like that? But that was where the first conference was held. So the facilities in the institution was rather basic those days, and the delegates were accommodated in men's hostel Bagayam. Now, coming to present day, the Department of Surgery became a specialty-oriented division of surgery in September 2011. Now, the general surgery department had units, 4 units, had their own subspecialty. So the first unit has head and neck, second colorectal and anal canal, and third, esophagogastroduodenal, and fourth, abdominal wall and retroperitoneum. And at this time, after this, the MS general surgery seats were increased to 10. How many are there today? 10 only. Okay, that is when it was increased to 10. Then we have specialty surgery. The other segment of division of surgery with peripheral vascular surgery, hepatopancreatobiliary surgery, and endocrine surgery. The specialty surgery leading on to MCH. Now, sorry about that. Now, it was then, after that, we were still the Department of Surgery, because of our cohesiveness, we performed the very first liver transplant, not as specialty department. We were all general surgery. It was the general surgeons who performed under the umbrella of general surgery, the first liver transplant, both cadaver liver transplant and a live donor transplant were performed. And those early ones, they are still alive, doing well. Okay, so this is our heritage. Thank you very much.
Thank you, sir. So just carrying this forward where we are now. So we will just take over from where Dr. Banerjee left. So this, the year 2000 was a landmark year for our surgery department. So this was our centenary celebrations and also the 50 years of PG training. Okay, so there was a conference and a meeting, and basically this is when the idea of specialty-oriented surgery sort of took place, and 6 specialties were identified. Yeah, sure.
They were the first faculty as well as the first trainees of the Department of Surgery. The faculty, Dr. Paul Brand is here, and all the others were our trainees starting. And the other faculty, Dr. Jacob Chandy. So Dr. Jacob Chandy, Dr. Paul Brand were the earliest faculty over there, and all the others were our postgraduates who were part of the organization. Later on, they went to different places, but they all came together at that time. It was the first time we were able to, by organizing this Golden Jubilee, we had all these people came, and all up behind, we had black hair at that time.
Still handsome, sir. That was when they thought of this, the real sort of transformation of specialty-oriented surgery sort of started there. And over the next 3 years, there were a lot of meetings, deliberations on, what would happen. And it was in August 2003. This was the surgery 1, 2, 3 units, which split into 6. So this is the photograph that was taken in August 2003. All the 3 surgical units, the entire department, including the surgical ICU, Dr. Nagamani there. So then S1, S2, S3, the 3 surgical units became 6. It was quite confusing at that time. What is 1, 2, 3, 4, 5, 6? But that's how the division took place. And the 6 units that were formed were 1, 2, 3, 4, 5, 6. Head and neck, peripheral vascular, upper GI or foregut, hepatobiliary, hindgut or colorectal, and endocrine. And they all had, the center was, so each of these units were doing general surgery, and they were doing their own specialty oriented surgery. And in fact, this, I think, was the golden period of the general surgery department, where we all stayed together. We did our own specialty things under the umbrella of the Department of Surgery.
We came together in the midgut.
Correct. So midgut held us together. And as you can see, there are 3 GI units and 3 non-GI units. And each GI unit partnered with and shared offices and ward with the non-GI unit. So it was a fantastic setup at that point in time. And come year 2010, then there was this option for the Department of Surgery to start the MCH courses. So 3 of the 6 units then decided to start their MCH training program. And then the remaining 3 had to be made into 4 because we had an increase in the PG seats to 100. So we needed to have 4 units, 4 general surgery units, and the 3 specialty units. So the Department of so there was this division of surgery which had the Department of General Surgery and the Department of Specialty Surgery. So the 1, 2, 3 were the same, and a new S4 unit was created, which was under Dr. Nayak, which was to look at the abdominal wall and retroperitoneum, and of course the 3 specialty units. So then on, so that is the current form that we are now. We have the 4 units and the specialty units, which have branched off, but under the division of surgery. So I would just briefly tell about each of the heads of the units here. As far as surgery 3 is concerned, Dr. George Matthew was the head when the split happened. He retired in 2001, and since then we have in the upper GI unit carried this forward. We started our fellowship program, which we currently run. I think there are 2 huge things that happened since as far as upper GI is concerned. One is, of course, the majority of what we do now has become minimally invasive. Now, if you look at this picture here, this is how an esophagectomy was done. And this is you cut open the chest. Patients used to spend days, if not weeks, in ICU. But now all that changed in 2012 when we sort of moved on to minimally invasive for our esophagectomies. And basically this is now our standard sort of routine. And of course, we also took on bariatric surgery, and that also forms part of our work. So this is some of the pre-COVID, we sort of conducted an international conference. So we are part of the Indian Society of Esophagus and Stomach Diseases. And of course, the most recent thing is our robotic upper GI surgery program. And the second thing is the multidisciplinary approach that has come into vogue in not only benign, but also not only malignant, but also in benign surgery. So what is in the horizon for surgery in general and also surgical specialties? Now we are seeing sort of blurring of boundaries between surgical and medical specialties, increasingly collaborative now. A general surgeon has to be a multilinguist, cannot just do surgery, not just cutting and stitching up, but you have to understand the language of medicine, genetics, radiotherapy, bioengineering, etc. AI and digital technology. We need to learn to adapt to changes. Many of the operations that, for example, that I did as an intern or a registrar doesn't exist anymore. The vagotomies have gone. So we sort of have moved on. And along with this, the changes in the training of the surgical trainees with the evolving innovations. Challenges for general surgery, how to sustain general surgery in the era of super specialty. So it's actually not subspecialty now. It's called super specialty exams and super specialty. So how do we sustain general surgery? How can general surgery still cohabit? You know, I talked about the golden period where we had general surgery and the 6 units. How do we have? How can we cohabit with the subspecialties? How to keep the evolving specialties rooted to general surgery again is a big challenge that we are facing. How do we continue to impart holistic patient care and surgical training? Again, that is a challenge. So this is our division and a recent photograph. So I'm going to request the other heads of the surgery units to just tell us a little bit about their own units since we moved on. So firstly, Dr. Cecil.
Yeah, welcome to all. It was a nice experience to go through the history. It was a reminder as much as this session is going to be informative to you, because many things get fallen as we go along the way. So the unit, as I know, is pictured here, but we started in 2003. And the specialty that was given to us was head and neck, but our focus was always on general surgery. Some of the things that we had kind of pioneered or contributed towards the department was in the field of education, and especially with the incorporation of technology. So these are some of our pictures of some of the earlier skills lab boards that we had made, and this was a session that we used to take for interns and postgraduates. We also took a foray into the technological aspect, especially with e-learning platform that was there. And a brief stint at Tufts University helped that. In 2015, we had tried to formalize assessments. We have ways of assessing students and PGs, but we had tried to formalize that with our own versions of, the observed clinical case and the practical performance thing. Rita is the name of the PG assessment tool. And right now, Dr. Emmanuel is incorporating this into Microsoft Teams. So trying to again use technology to incorporate all of this. In 2013, we had started the fellowship in general head and neck or oral oncology and reconstructive surgery. This fellowship, of course, has now passed on to the new department. We continue to take sessions in various different, this is just the diversity of places where we were involved with in education, including sessions, educational videos, and even something that was loved by students at that time, anatomy dissection sessions in conjunction with the surgery department. In 2017, in honor of Dr. Jasim, who was retiring at that year, we had a very unique CME, which was on surgical education, and it was well received by many. We had experts from different parts of the country. Audit is something that all the surgery units do. This is a way of ensuring quality. One thing that we had done is these were all developed in-house ways, databases to incorporate the audit. And we have a running line of data now from 2018. We had started in 2008, but the running line is from 2018. First on Access, and now we are using the institutional SharePoint. We're just moving on to that for incorporating all these data. We've always been involved with certain centers outside, extending surgical services here. We had started with the low-cost effective care unit. A lot of stories to tell about that. And then we have added on Chittoor campus. This is Chittoor campus as we know it. It's very different now. And CHAD and Mission Hospitals. Research also, we have had our stint with cutting edge research, things that were trending at the time, sentinel lymph node, HPV, etc. And we have now moved on to general surgical topics like diabetic foot, gallbladder, and hernia. I've been appraised of the history of head and neck surgery. This is something that many might not know, but my former HOUs have told me. The history can be traced from the time of Dr. Somervell, who was the first person involved with the surgeries, handed through a line by Dr. LBM Joseph, Dr. GT Simon. But the immediate predecessors who handed the mantle over to us are Dr. Ravi George, Dr. Philip Korla from plastic surgery, and Dr. Raman from ENT. It was up to Dr. John C. Muthusamy, who had a brief stint at Tata Memorial Center in 1992. That's the erstwhile surgery 2. And he picked up the work in S1. We have had many other trainings after that, short trainings in microvascular surgery, junior training fellowships by various senior faculty, senior training fellowships again by various senior faculty in various aspects of reconstruction and head and neck. And many of these things had been incorporated into the normal working routine of the unit. It was a longer stint by Dr. Rajnikant as part of his study leave in Australia, wherein he picked up on aspects of facial trauma, head and neck malignancy, and microvascular recon. But the call for head and neck surgery was much bigger and could not be restricted to the confines of a broad specialty department. This did not come in the initial phase of the super specialty department. They came much later on. So in 2016, Dr. Rajnikant and Amit from Surgery 1 moved along with Dr. Rajiv Michael from ENT to form the head and neck surgery department. And in 2022, their long cherished dream of having an MCH had come to fruition. And the first seat has already been taken that day. We continue to grow as a general surgery department, and now we are pushing our boundaries in abdominal wall reconstruction, including laparoscopic and robotic surgeries. Again, in the field of breast, where Dr. Ajit John George, who's on study leave, is currently pursuing a breast fellowship. We've been involved in all of these skin cancers, diabetic foot and clinic, along with endocrinology, and we continue to do general head and neck and oral oncology. One of the things that is quite unique is a tradition that has lasted for many decades, and many doyens sitting here are the people who are behind it. And this is the P2 ward party. There are a lot of traditions that keep going, and these pictures are snippets. Those of you who have gone through it will know what those mean. So the department still continues to grow, and I think we stand on the shoulders of greats before us, and we hope that we will continue to, push this vision to its boundaries. Thank you.
Thank you, Cecil. May I invite Dr. Rohin now, please, from colorectal surgery.
Good morning. Thank you. It is indeed sort of humbling to listen to the history of general surgery from where it started and where we have come. Over the next 5 minutes, what I will sort of try to go through is some of the things that the colorectal unit has done in the last decade or so. A lot of this is possible only because of our unique approach, which is the specialty-oriented general surgery, and because of the support of the institution, which is CMC, which has allowed us to grow and to do what we can do. I'm going to go through just a couple of things, both in sort of service provision as well as education and research. And I really want to take you through a sort of a unique story of what I think is only possible here in CMC. And I've labeled it the jelly belly story. So this is a picture. It is a screen grab of one of my presentations that I did in 2010 in the clinical meeting which just happened here an hour ago. The meeting that Dr. Banerjee was talking about. This was a patient who came in with this huge tumor in the abdomen, a jelly full of mucin. And at that point, all we could do was debulk this tumor and then send the patient home. And then it would regrow and we would debulk again. And this is again a screen grab of my slide from 2010, where we say that CRS and HIPEC is practiced in very limited centers worldwide. It was a new treatment coming up. There were probably 3 centers in the world which were doing it. And I have said here saying serial debulking is the only palliative procedure. And I remember standing on this podium and saying, this is only for mavericks and this is not for everyone. 2 years later, I had an opportunity to observe and learn this procedure via the JTF offered in CMC. Then in 2014, I was sitting in OPD and there was this young man who had this jelly belly. And I said, hey, listen, there is this new procedure. We've seen a few. It is possible. Would you like to, go for it? And he looked straight at me in the eye and said, how many have you done, doctor? And I said, none. And he sort of looked back. He said, give me a few days to think. I went to Dr. Banerjee, who was then HOD, and I said, I've seen this during the JTF. We want to try this. And he said, please go ahead. I will be there. This patient then accepted. We did the first procedure in 2014. Patient still alive and well. We then further, through study leave, have trained. And today, then gynae oncology also started doing CRS and HIPEC through Dr. Abraham Pedicle and his team's help. We got the machine. And today we have done more than 50 procedures. Every member of the colorectal team is now trained in this. And we are one of the centers which probably does one of the highest volumes in the country. And I think this is testament to specialty-oriented surgery and to the institutional support that we get to be able to do such cases. We are now, this is something routinely done. We do about 1 case a month or 2 cases a month. And then now we're expanding the use of this to other cancers as well. So now we are starting to use the same principles that we've learned from this to colorectal peritoneal metastasis, cancers which had a median survival of 6 months. Now we can offer up to a 4-year survival with this procedure. And the next step to that is PIPEC, which is pressurized intraperitoneal chemotherapy, which we hope to introduce in the near future. Thanks to Dr. Ranjan and planning of the new theaters. One of our new theaters is going to be ready and PIPEC compliant. And we hope that once the new theaters are ready, we will be able to use this new technology to offer better care to our cancer patients. The next thing I would like to touch upon is comprehensive colorectal cancer care. Dr. Inian touched upon this. I think the whole department is very sold on the idea of MDT-based approach. I remember MDTs way back in 2005 and 2006 in the RT classroom. We've come a long way. We moved to MDTs, not just in cancer, but also in benign diseases such as inflammatory bowel disease. And we individualize treatment to patients. What is unique is that we've had periodic colorectal cancer protocol development meetings with all stakeholders such as radiotherapy, medical oncology, radiology, pathology, and we have our own guidelines which actually are used quite widely nationally. We also have a colorectal cancer registry since 2008, which now has more than 2,500 patients. And a lot of it is teamwork in working along with a lot of other patients. Our MDTs are quite popular, and now as a unit, we have been charged with conducting national tumor boards to be able to promote the concept of MDT all over the country. We had the first national MDT 3 months ago, and the next one's coming up next week. Dr. Inian's a part of that one as well. And so our work is being recognized all over the country. We've always adopted new technology. Dr. Inian again mentioned about the use of laparoscopy. This is one of the very early pictures, maybe about 10 to 12 years ago, where Dr. Ranjan, back from study leave, is doing one of the first, earlier laparoscopic surgery, and that's me sort of assisting and holding the camera for him. We moved on from there. We now have the surgical robot, and we've done more than 110 cancer cases in the last year and a half. We've also moved on to try and do organ preservation. We are now providing transanal minimally invasive laparoscopic surgery, where we can do laparoscopic transanally and remove cancers which earlier required a radical surgery and probably a permanent stoma, which offers better quality of life to patients. A lot of this is possible not just with our team, but also with our nursing team. We've got an excellent stoma nursing team. We recently started a colorectal cancer nurse program, which is the first in the country. And our nurses have taken it to the next level. And this is them organizing a whole colorectal cancer awareness program last month to increase awareness. And the next step which they want to take on is actually screening, so that we can actually prevent, pick up colorectal cancer early. Education, we've got a 2-year fellowship running in colorectal surgery. It was one of the first fellowships in the country. After years of talking about it, we've finally got the first approved colorectal surgery course in the country. And the curriculum for this is based on our fellowship. The hope is that it ultimately converts to an MCH in colorectal surgery. We also had multiple international training fellows, and our unit is recognized as an international training site by the Sri Lankan Surgical Society. Part of training is to organize conferences. We organize an international conference every 2 years, and this is the last conference in 2023, where over 250 people participated. Research is also a central focus for the unit. We do clinical genetic and microbiome research. There are collaborations with other centers such as IISc, multiple multi-center studies, and some national studies on relevant topics. One of the key things that we've done is partnered with the NIHR Global Health Research Unit on Global Surgery, and we have been awarded the South India Sub-Hub for Surgical Research. we look at the whole focus of this is to identify lacuna in surgical care in the global south and develop local priorities and questions in surgical research. What we want to do is promote local surgical research to answer local questions. And we've set up a whole surgical office for that. And all surgical units are welcome to participate in this. What is the future vision? The future vision is to use continued use of technology to provide state-of-the-art care and tailor treatments based on our local needs and assessment for our patients. We are in the process of setting up a pelvic floor lab, and we hope that will be up and running in the next few years. A PIPAC for colorectal cancer. And then one of our other projects, along with our stoma nurses and with some NGOs, is to look at affordable and accessible stoma care appliances for patients. And hopefully we'll have more about it in the next session. Thank you.
Thank you, Rohin. And lastly, could I request Dr. Titus? Dr. Suchi is away today. So thanks, Titus.
Good morning. I'm humbled and privileged to stand here on because of Dr. Suchita to tell about Surgery Unit 4. As Sir already mentioned, we are the youngest unit. We started, basically there was a need to start 100 UG seats. So we have to make it 4 units. 3 units have gone into super specialty. When we started by Dr. Nayak sir, one of the most dynamic, versatile surgeon I have come across. He headed the unit. He was working in colorectal. He moved to this unit, and he was strongly supported by Dr. Suchita Chase and Dr. Beulah. And then the young boys came into the unit. So, so this is the team. And the specialty which was given to us is hernia and the retroperitoneal tumors. And we have taken it forward. Our focus when we started in 2012, it's mainly teaching. Either it is MBBS teaching or in PG training or junior consultant training. Even to 12 years down the line, these are the last 2 years data. We are still continuing to teach, and the PG teaching still high, 43-44%, followed by junior consultant, and finally the senior consultant. And we hope to continue to do so. And it's not only about teaching and working hard, it's all about having fun, and which Sir Nayak sir and Suchi ma'am called it as S4 family. So we always have every 2 to 3 months some gathering in some place, and this is the last month we had in Nayak sir's house. And this gathering is all about family coming together. It's not the consultant or the PGs meeting and having some fun, and the kids included, and we have really great time. And this thing continues with the teaching also. Clerkship dinners, this is one of the earlier time when the clerkship started. And this is Nayak sir, we had a dinner, I think it's Avna Inn, and with all the clerks, and some of them have become PGs and soon going to become consultant. You can see them there. And this is one of our most favorable time. This is just before Nayak sir retirement. We had a get together in Munnar. We plan these kind of trips also at least once in 6 months. So we went to Munnar. This is again S4 family together having a wonderful time. Moving on, like Sir mentioned, the golden period of general surgery. It's the tough balancing act of developing your specialty and gluing on to the general surgery. And it is difficult. And we have 2 specialties given to us. One is sarcoma, other one is abdominal wall reconstruction. As you can see, we are trying to maintain the balance, still doing 60% of general surgery and around 30% of AWR and 10% of sarcoma work. And 2 specialties given to us. One is abdominal wall reconstruction and other one is sarcoma. Starting with abdominal wall reconstruction. And first we started with AWR specialty nurse. This happened almost 4 years back, and worked on that. We started a AWR clinic. It's almost 2 years running. Anybody who has a complex hernia, a hernia with a lot of comorbidities, can refer the patient there, and they will be optimized in their comorbidities, their physical fitness, their diet advice, and then they'll get ready for their operation. So it takes, depending upon the patient, 1 or 2 months to get them ready for the operation. And like the youngest team in that unit, we also jumped into the robotic, the latest, probably another last 10-11 months we have been doing robotics. We have done more than 51 cases so far in robotic, including so many abdominal wall reconstructions, and 2 of us were already trained, and the 3rd person is ready for certification. And this is again taking on the principle of Nayak sir, is like, see one, do one, and teach one, and we are continuing to do that. And our specialties, otherwise, we started the AWR fellowship. This year we started, 2 fellows have joined us in this year fellowship. We are hoping to continue and making it a recognized fellowship, Tamil Nadu Council. And we conducted AWR Road to Search National Conference this year, and this is the team, and this is the conference. More than 30 national faculties have joined, and 5 international faculties joined. The next specialty is the sarcoma, and that is again one of the rarest tumors. And initially, Dr. Beulah went for her JTF fellowship to Italy in 2017. 2022, I went for the fellowship, and we conducted the STS Con in 2018. That's the international conference with more than 10 international faculties. Since then, in the retroperitoneal field, we have been doing compartmental resection with almost 20 to 25% increase in the decrease in the tumor recurrence rate. So that is a great achievement in the field of sarcoma. And we are also part of TAR-PSWG. Along with them, we are into giving our data and contributing to their data collection, as well as getting their input in managing cases. We have had few MDTs online with them to manage how difficult cases are. And currently, Dr. Beulah is doing sarcoma melanoma fellowship in Australia, for it's a 1-year course. So our future plan in both these fields, we want to conduct a lot of cadaveric lab workshop, as well as live surgical workshop in the field of AWR. And we are planning to start a sarcoma postdoctoral fellowship as early as possible. And finally, tumor banking and research in the field of sarcoma. Thank you.
Thank you, Titus. So that is the history of the surgery department in the bigger context and the bigger story of the institution. So the history sort of unfolded from the first patient that I discussed saw through the evolving of the specialty units, the teamwork with other departments, of course, surgical nursing, the sacrifices which were made by some for the benefit of many. So I think it's a great story. And thanks to Dr. Banerjee for actually writing it down. And I think, as I had mentioned earlier, we have to take this forward. This book has to be revised, and we will certainly look into it, sir. So I again thank everyone who have presented, the heads of the units here. And we have to carry this brand of surgical training and surgical care forward. I think that is a great responsibility that we have. And I have to say that all this was possible only with the help from above. So we have to thank God for all the help. And also we look, the future, there are challenges, and I'm sure with the help we will be able to take this department forward. Thank you, one and all.